Now we cut across to the other very important part in diabetes, and that is type 1 diabetes, and specifically to address certain issues that are not always addressed. And for this type 1 diabetes masterclass, the forgotten issues or the not talked about issues, we have with us a very robust panel, and that is being led by none other than Dr. Sujoy Ghosh. May I have his introduction slide coming up, please? Yes, he actually needs no introduction. He is an endocrinologist in the field of endocrinology and diabetes. He is very much a big presence on the Indian scene. He's a consultant in the Department of Endocrinology at the AMRI hospital in Dhakuria, and he has huge experience. And I'm going to hand over this session now to Sujoy so that he also introduces his expert speakers on his panel, and I ask him to take this forward. Over to you, Sujoy.
Thank you, Dr. Neeta, for that kind introduction. And it's indeed a pleasure to be part of such a wonderful conference and be part of such a wonderful team that I have for today's session. And without wasting much time, we are going to talk about type 1 diabetes and the issues that we usually do not discuss, because whenever we talk about diabetes and when we discuss about issues of type 1 diabetes, it's mostly about monitoring, how to have healthcare access, weight gains, growth, and stuff like that. So we are going to first talk about the first issue that's not talked that much, is about non-insulin therapies. We all know that insulin is the backbone of therapy for management of type 1 diabetes. But what about the other anti-hyperglycemic agents that we could possibly use? And to talk on that, I have none other than Professor Vagish Iyer, who's an endocrinologist that all of India knows. He's had great publications, great teacher. Over to you, Dr. Vagish, for your bit on non-insulin therapies.
Thank you, Sujoy Ghosh, for your kind introduction. Thank you, Neeta and Dr. Anjali, for your invitation. Next 7 or 8 minutes, I'll take you through a journey of non-insulin therapies for type 1 diabetes. We know that type 1 diabetes results from beta cell destruction. Insulin therapy is a cornerstone in the management, but it has its own limitations and drawbacks. That's why I think everybody was thinking something much more than the insulin can be given for these individuals, which are used in even other types of diabetes. So what are these drugs which are commonly used so that we can implement in patients with type 1 diabetes? The most common one which was thought of was a metformin, because it was available for a long time. But the trials involving metformin in type 1s are very, very limited. Among one that was a removal trial involving around 420 excess type 1 patients. And what they looked into is somebody is above the age of 40 years, somebody is hypertensive or obese. They wanted to look at the carotid intima thickness in this trial. And what they found that there was no effect of carotid intima thickness, but HbA1c came down by 0.34%. But most patients had a GI intolerance like any of our type 2 patients. Then many more came, Pitacos trial and the other one in 2018. But all of them, what they showed is, yes, there is some amount of a weight loss and the HbA1c reduction, but this was not sustained. So what the final thoughts about metformin in type 1? HbA1c comes down initially, but it's not sustained if you use it for a long time. But it does reduce the daily insulin doses. But we need to look at the weight loss, that is also initially is there, but long-term data is lacking. But most important, it doesn't increase the severe hypoglycemic events. So when used in type 1, initial benefit with HbA1c and the weight is there, insulin dose comes down, severe hypoglycemia doesn't happen, but we don't have a great number to support for a common practitioner to use metformin in type 1 diabetes. Then we'll move to the next drug that is the most happening drug, that is SGLT2 inhibitor. So there are lots of evidence to support, and also there are some recommendations to use this in patients with type 1 diabetes. It has been observed that it does reduce the HbA1c, and also it doesn't increase the risk of a severe hypoglycemia. That is one of the major concerns with patients with type 1 diabetes. So this is a meta-analysis which is available, published this year. So it looked into the, I think, more than 2,000 publications which were there, but they were all small not properly controlled. In the end, they could get only 17 studies which would address the issue what they wanted to look into it. And they found that there was significant reduction in the HbA1c when they used SGLT2 inhibitor in patients with type 1 diabetes. And also there was reduction in the body weight. Most of these patients were using insulin, then that's why there was no increased risk of a ketoacidosis, which was seen with type 2 diabetic patients when it was used as a fourth add-on instead of insulin. So good reduction in the HbA1c with good reduction in the body weight with the SGLT2 inhibitors in patients with type 1 diabetes. Then comes the next agent, that's the GLP-1 receptor agonist. So it's quite fascinating to know the mechanism of action of GLP-1 receptor agonist, so that it slows the gastric emptying, it stimulates the insulin secretion, but that doesn't happen in patients with type 1 diabetes, but it does suppress the glucagon secretion. Hence, they thought of using this in patients with type 1 diabetes, but there are very, very small studies. I think you can see from 2016 to 2017, there are hardly 4 or 5 studies involving in excess of 2,000 patients studied from anywhere from 6 months to 1 year. But what that has shown is none of these studies have shown the impact of this GLP-1 analog on a HbA1c. That is one of the most important glycemic parameter. What we look in patients with type 1 diabetes has not happened. But what has been happened is some amount of decrement in the bolus insulin has happened, mainly because of the action on a glucagon. But otherwise, there is no major impact of this drug on type 1 diabetes. Then comes the pramlintide. This is the one which is in use from 1987. Quite promising action because it gets co-secreted from pancreatic beta cells. It makes the person to feel full. Hence, the meal size comes down, the appetite comes down, and it has also got some benefit on the glucagon secretion by suppressing it. Hence, they thought this can be used as an adjuvant therapy in patients who are on the overweight side, so that their meal size comes down, even the weight comes down. These are the few studies which have been done using pramlintide in patients with type 1 diabetes. There are around 1,000 plus patients studied anywhere from 1 month to 1 year. And we have seen some beneficial even in the small studies. Thing is, there was a positive effect on the HbA1c and the weight. Total daily insulin doses came down, but it was not very clear in all the studies across it. There was reduction in the postprandial hyperglycemia that was quite strong indicative across the studies from 1 month to 1 year. There was no increased risk of a severe hypoglycemia, but main concern is already these patients are on minimum 4 subcute injection. They need to take additional 3 to 4 subcute injection when they are using pramlintide. That's one of the major concern because their monitoring plus pricks, totally that puts them anywhere close to 10 plus pricks per day. What about the DP4 inhibitors? These are in the use from past 1.5 decades. There is quite widespread use of DP4 inhibitors in patients with type 1 diabetes, but none of them were randomized control trials. There is no convincing effect on HbA1c with the use of DP4 in patients with type 1 diabetes, but only thing which has been very much promising that probably it will preserve their beta cell function so that endogenous insulin gets retained, but no firm conclusions have been reached out of any of the studies they have done. Probably the agent requires much more research and probably will get more clarification in years to come. So this is a meta-analysis of all the drugs which have been used in patients with type 1 diabetes. You can see right from the metformin, which I studied, AGI, very few numbers. That's why I didn't grow in detail with ZDs and the EGI, GLP-1 receptor analogs, DP4 inhibitors, SGLT2 inhibitor, and pramlintide. These are all the drugs which have been done, but very few are properly randomized control trial. In the end, you are left with handful of studies which are of some conclusive research messages. What they say in the end is the glycemic control is overall good compared to the placebo in patients in whom they use this adjunct therapy in addition to the insulin, with good reduction in HbA1c and the body weight. Dosage of insulin reduced in most of the studies, and risk of hypoglycemia, especially severe hypoglycemia, was less in these agents. So to conclude, it is clear that treatment of type 1 diabetes is evolving even now from past 100 years. Short-term results up to 1 year with adjuvant therapies are not encouraging when it comes to the HbA1c and the weight aspect to the great extent, but we require long-term studies where they can look into the glycemic profiles, fluctuation, even a CV outcome, so that this adjuvant therapy can be made to useful for patients with type 1 diabetes. I think I stop my presentation here. I'll hand over to Sujay for his next speaker.
Right. Sir, would you stay back at the end, or shall we take your questions right
away?
I
can take my questions, no problem.
Right. There are no questions in the chat box, but if I could ask you from a practicing clinician's point of view.
Yeah.
Now, we have the evidence in front of us, which you've summarized quite well, saying that these drugs might be useful adjuncts in terms of reducing the risk of hypoglycemia, possibly improving in terms of reduction of insulin doses, but we still don't have much of an evidence consistently about weight reduction or consistent HbA1c reduction in the long term. So from a clinician's point of view, if you have to use any of these drugs, where would you be using these drugs, and which ones would you be recommending use in patients with type 1 diabetes?
I think I'll be using a metformin, to some extent SGLT2 inhibitors, to a greater extent somebody who is obese, has got features of insulin resistance and a difficult weight to shut down. Fine, that is the one which I'll be using. And other one which I have used earlier but not continued was GLP-1 receptor agonist, because none of the studies were encouraging. But if patient is ready to take a prick, one which will be confidently I'll be using is pramlintide. That is the one which will be the most safest thing to use. Rest all, I think, with lots of
is it readily available in India?
No, it is not available. They can procure from West.
Okay. So and I'm being naughty. How many patients have you actually used SGLT2 inhibitors in type 1s? Because I haven't.
No, I have got only one patient who was taking it. I continued it. I didn't discontinue. So I was part of using it, but not the recommending physician.
Right. So I would completely agree with you that there's a significant proportion of kids or young adults with type 1 that I do use metformin, particularly ones requiring higher doses, ones who are putting on weight, and ones who are not having that greater response to whatever doses of insulin. And what about pioglitazone? That's again a drug which maybe a couple of years ago we were still using more in patients with type 1s with less fear of weight gain, because particularly the under-insulinized kids, weight gain was not an issue.
Yeah.
I think there as well.
My experience with pioglitazone is almost close to zero with the type 1 only thing, but now use of pioglitazone itself is on the marginalized even in a type 2. So probably I think we have a less future for it compared to what we have discussed already.
Right. And the last question, I see a lot of clinicians, and I've used this off-label as well. See, someone is on a basal bolus insulin, taking 3 shots of boluses, and then there's an evening snack or an afternoon snack, and the kid refuses to take another shot of insulin. What about using an AGI in that situation? And I know this is a completely off-label indication that I'm talking about, but what is your experience, sir?
I think I recommend them to take a rapid-acting insulin shot rather than a AGI. So even the studies regarding AGI is very less, except confined to our Asian subcontinent. We hardly get anything from Europe or US, this literature. Probably, I think if we are using it, I think we should pool our data, make it more acceptable for the publication.
Right. So I would summarize and say that metformin is probably the one that we would be using most commonly in our kids with type 1 diabetes. Thank you so much, sir. That was wonderful. Not only the presentation, but the practical aspects. Yes, ma'am.
May I add, just off-label use, I must admit, I have used metformin in quite a few, especially older girls who have post-puberty, they're overweight, and even SGLT2 inhibitors with adult above 28 BMI requiring large amount of insulin. And to date, I have 5 patients who are doing very well. It's all off-label, so I'm admitting it here. And also AGIs have worked well, especially the ones who have a very high carbohydrate. Because I work in rural areas, their major meal is carbohydrate. They cannot often afford the evening snack, which is not. And when it's not possible to, we have tried it. So far with good results, and I agree with sir, it should be documented and followed up. But so far so good.
Nice.
Thank you, ma'am. Thank you, ma'am. Thank you, Professor Vagish, for that excellent presentation. We move on to our next speaker, Professor Ganapati Bantwal, who needs no introduction. Sir is right now the president of the Endocrine Society of India, and it's a pleasure for me to work under his guidance. And Sir is professor at St. John's, Bangalore, in the same institute as Dr. Vagish. And Sir also has published numerous publications and is a teacher of several of the currently young generation DM endocrinologists. And Sir is going to talk on cardiovascular risk in type 1 diabetes. You know, we look at cardiovascular outcome trials in type 2 diabetes and so many drugs and so many things about statins, hypertension control, and glucose control in type 2. But type 1 is probably one area which is relatively neglected. Sir, the stage is all yours.
Thank you, Sujay, for that kind introduction. Let me thank Dr. Neeta Deshpande for giving me this opportunity to speak in this forum. I'll share my slides. Yes, as Dr. Sujay told, yes, we have a lot of data actually coming from type 2, but not much data is there on CV risk reduction in type 1. We have had the longest DCCT trial and the EDIC, which was followed up to 20 years also. So some amount of literature, a little bit coming from that also. So there was actually in 2014 comment from the AHA and the ADA on this. So as you know, type 1 diabetes is associated with a premature cardiovascular disease. Even at age less than 40 years of age, men and women with type 1 have a 5 and 10-fold increased risk of experiencing a coronary heart disease event. And this risk is still higher if you still have a younger age of onset. And it has been found that by the age of 20 years, life expectancy is reduced by approximately 12 years in absolute terms, with approximately 1/3 being attributable to cardiovascular disease. Like all CVDs, which is decreasing in the general population, the same thing is happening even with the type 1 diabetes also. But then in a recent meta-analysis or in a recent analysis of more than 10 million individuals in the UK National Health Service, type 1 was still more strongly linked to CVD outcomes than any other disease. It was also linked to a higher incidence of heart failure than even type 2 diabetes. And as you know, unlike the traditional risk factors, hypoglycemia, they have a more profound effect on cardiovascular risk in type 1 than type 2. And the other risk factors like hypertension, dyslipidemia appear to be having a synergistic rather than an additive role. And if you see the standardized mortality ratio attributable to cardiovascular disease is 5.7 for men and 11.3 for women with type 1. And by the age of 45 years, more than 70% of men and 50% of women with type 1 have developed coronary artery calcification. Though there has been an improvement because of the improved management of the traditional cardiovascular risk factors, there has been an improvement in survival. There's a 29% reduction in the relative risk of death over a 10-year period. Such that right now, the risk for CVD is 2.3 for men and 3 for women. There's an increased mortality. In the first decade, acute infections, hyperglycemia related, dead in bed syndrome, hypoglycemia related. Second decade, CKD and cardiovascular accidents. Third decade, so that is 30 years of diabetes history. Now, the cardiovascular causes the most important, being the most important reason for mortality. So the UK cohort study showed that patients with a history, diabetes history over 30 years, there was an increase in CVD, such as hypertension, cardiomyopathy, heart failure, and MI. Risk factor, as I told you, HbA1c, blood glucose assessed by HbA1c, most powerful risk factor. Others like blood pressure, LDL, they have a contribution, but then it's only after 15 to 20 years of diabetes. And in the Swedish National Diabetes Register, type 1 diabetes who had an A1C, approximately say 6 millimoles or lesser, rather 6%, they had an increased risk of death from cardiovascular cause, which was twice as high in the risk in the general population. And this risk increased with more higher HbA1c concentration. And it's also related to more strongly to fatal rather than non-fatal CVD events. So in the Swedish trial, they found that every 1 millimole increase in LDL, it translated into a 9% increased risk of CVD in individuals without lipid lowering medication. And though LDL is, when you treat LDL, it does come down, but then it is not a good marker for cardiovascular risk in primary prevention in patients with type 1. Similarly, the Eurodiab study also found that LDL not predictive of CVD. So what's happening? We are probably, because of this, there is a tendency to develop an atherogenic lipid profile, which is actually hidden. So what could be the reason for this? They have more amount of intermediate density lipoprotein, increased small dense LDL, and HDL, which may be even more, but they are dysfunctional. And this HDL levels are even high unless the control is poor or nephropathy has developed. Hypertriglyceridemia can also occur. As you know, hyperglycemia can lead to hypertriglyceridemia, and this is also, the risk is associated with it stronger than in the general population. Coming to the differences between the specific cardiovascular risk factor in CVD events in type 1 versus type 2. Hypertension, more effective for type 1. Cigarette smoking, the same. Inflammation, the same. Hyperglycemia leading on to inflammation. High LDL, it's more for type 2 than for type 1. Low HDL, not so much for type 1, but then significant for type 2. Triglycerides, mainly for type 2. Microalbuminuria is a significant event in both type 1 and type 2. As you know, it heralds the onset of hypertension, and it suggests there is an endothelial dysfunction throughout the body. In other words, the cardiovascular dysfunction is also happening. Insulin resistance, big contributor in type 2, but not so much, and poor glycemic control in both of them. How hyperglycemia causes atherosclerosis? As you know, it leads to oxidative stress, generation of superoxide anions, and leads to the activation of all the pathways, the protein kinase, the advanced glycation end products, hexosamine, and the polyol pathway, and inhibition of protective pathways like the endothelial nitric oxide synthase and prostacyclin synthase. So you can see here, decrease in insulin leads to hyperglycemia, increased age, leads to inflammation, leads to endothelial dysfunction, decreased nitric oxide. There's a reduction in the reverse transport. So we have an increased dysfunctional HDL, increased IDL, small dense LDL, increased oxidized LDL. All this contribute to the CV risk. Recently, they have found that another factor which could actually contribute to this is the development of anti-myosin antibodies, which could probably lead to inflammation and finally to the atherosclerotic vascular disease. They have proposed this. So we don't have much data. So these are some of the studies where they have found. So you have the UK GPRD study, the General Practitioner Research Database, duration of 15 years, follow-up of 7 points. So what they found was MI, coronary revascularization, stroke, and acute CHT deaths were more in men and also women in type 1. Similarly, the coronary heart disease was once again more, threefold in men and around 7.6-fold in women. Similarly, in the nurses' health study for CVA, fatal and non-fatal stroke, excluding silent strokes, were more common in women 6-fold compared with women without diabetes. And similarly, the peripheral arterial disease were once again incident non-traumatic lower extremity amputations were more in these patients. So, as I already told you, in the UK GPRD, compared with the general population during a 4.7-year follow-up, there was increased risk of coronary heart disease. And this cumulative incidence of coronary heart disease ranged between 2.1 to 19%, with the cumulative incidence of 15% over 15 years of follow-up. And the mortality rates over 14 to 18 years were between 6 and 8%, was higher in men than in women, and higher in those more than 40 years of age than in those less than 50 years. So cerebrovascular events were also once again higher in the type 1 diabetics. Similarly, it was the same thing seen in the Wisconsin epidemiology study of diabetic retinopathy, an incidence of 6% over 20 years, 0.3%. And the Eurodiab also reported 0.74 incidence of cerebrovascular events. Peripheral vascular disease, you have various methodology by which you could have an occult disease, by which you can assess it by an ABPI, extremity arterial calcification, or lower extremity non-traumatic amputation. And this was actually higher in type 1. And by 65 years of age, the study from the Swedish database, it was around 11% for women for lower extremity amputation and 20.7% for men, which is actually 86-fold higher. And similarly, they had even developed calcification of the extremity arteries in around 5%, more so in individuals more than 30 years of age. Now, what are the predictors of this? So when we say actually CVD, it includes coronary heart disease, the cerebrovascular disease, and the peripheral arterial disease. And the predictors were age, male sex, history of foot lesions or ulcers, diastolic blood pressure, LDL cholesterol, HbA1c, diabetes duration, hypertension, albumin excretion rate, GFR, smoking status, and retinopathy. And a meta-analysis found that with every 1% increase in A1C, the risk of peripheral arterial disease increased by 18%. And one important observation was glycemic control did not reduce that incidence. Subclinical CVD is also seen. So there was a study known as the cacti study, the coronary artery calcification in type 1 study. So they found there was an increased coronary artery calcification in type 1. And similarly, carotid intermediate medial thickness also increased in children, adolescents, and adults also in patients was seen. And this was seen in a very early age. Now, coming to risk stratification in type 1 diabetes. So common recommendations, they only consider diabetic retinopathy in the high CV risk. But in the absence of nephropathy, and various societies have not yet established consensus score to stratify the cardiovascular risk in type 1. So we have non-invasive tests like the intimal medial thickness, the ABPI measurement. So they provide a tool, opportunity to identify patients at high risk, CV risk after a 10-year history of diabetes. Patients with a high cardiovascular risk, if you have an IMT more than 1 mm or an ABPI less than 0.9, here you should do more aggressive treatment like lifestyle modification, ACE inhibitors, statins. We don't, they don't recommend stress testing or coronary angiography indicated only for very high CVR. Coming to the risk engines like the UKPD's risk in the Framingham, what happens with this is they do not account for glycemic control, duration of diabetes, or the presence of microvascular complications. So we had the Pittsburgh EDC study. Here they found that baseline A1C, duration of diabetes, low insulin dose, impaired renal function, increased albumin excretion, higher diastolic blood pressure, and lipid profile were all predictive of CVD. Similarly, the Steno type 1 risk engine once again had around identified 10 risk factors: age, sex, diabetes duration, HbA1c, systolic blood pressure, LDL, GFR, and albuminuria, and smoking and exercise. And age was the most significant risk factor, followed by time-weighted mean A1C. So the Steno type 1 risk engine, the QRISK, and the UKPDS risk engines. Coming to prevention strategies: stop smoking, increase physical activity, avoid weight gain. Glycemic control is very important. The EDIC, we found 42% reduction. Control of lipids with statins, hypertension control with ACE or ARBs. So this is a summary of the CVD risk. What do you do? Hypoglycemia, screen using A1C at least once in 3 months, target less than 7. Increased intensity of glucose monitoring and manipulation of insulin dosage you should consider. Diabetic kidney disease, of course, you do a urine albumin to creatinine ratio yearly, beginning 5 years after diagnosis. ACE inhibitors keep blood pressure less than 130 or less than 90th percentile for children. Dyslipidemia, what do? You do a fasting lipid profile, LDL less than 100, non-HDL less than 130. Children, once again, LDL less than 100. You could do the lipid profile once every 3 to 5 years. If they are adults with CVD, see that the LDL is less than 70. Of course, you have to use statins in these type of patients. And the goal is LDL less than 70. Hypertension, see that the blood pressure is less than 140/80. Start with lifestyle modification, low salt, a DASH diet. You could use medications like an ACE or an ARB and other drugs if required. Pre-hypertension, low salt diet, fruits, vegetables, regular exercise. And for thrombosis prevention, age more than 21 years. If they are an adult with CVD, then you can actually use an aspirin. So this is my last slide. As you know, not much data has been there for type 1 diabetes regarding the cardiovascular. Though we have a follow-up of the EDIC, the number of events were less, so it's very difficult to predict what is the exact strategy. So from the pooled analysis, whatever we have is whatever I told you now: hyperglycemia, DKD, dyslipidemia, hypertension, pre-hypertension. These are the things we have to stress on: control glycemia, avoid smoking, increase physical activity, and weight reduction. I think with this, I will stop. Yeah.
Right. Thank you so much, sir. You have managed to summarize so much of data in that 7 minutes. Awesome. Right. Couple of practical issues. If you look at, for example, the lipid guidelines, whenever it comes to the type 1 bit of lipid guidelines, clinicians are confused. So from a practical point of view, when do I start a statin or lipid lowering therapy in a patient with type 1 diabetes?
Yeah, so one thing is, we have a guideline for patients with familial hypercholesterolemia. And there they say, if you're aged more than 10 years, or if you have attained puberty, whichever is earlier, actually you can start them on statins. I think the same thing applies here also. If they have an LDL which is high, then actually I will start them on statin. Now, when will I start? Once they have attained puberty, then probably I will start them on statin in these type of patients. And I want them, I wouldn't say less than 70, I want the LDL to be less than 100 in these type of patients. So completion of puberty, and then I start them.
So completion of puberty, and what do you mean by high, sir, in starting? I'm sorry.
Well, say I want the LDL to be less than 100.
Right.
Though, as I told you, LDL is not such a thing. But then with a longer duration of diabetes, so more than 10 years down the lane, anything LDL more than 100, probably I will start treating them with a statin and try to keep it below 100.
Right, I'll come to Dr. Archana. I'll probably come to Dr. Archana on this a little later. One of the things you very clearly mentioned was, unlike type 2s, the risk is much, much, much higher in type 1s. That's something that the clinician should remember, because, unlike type 2s, the type 1s might not have that bad an LDL cholesterol unless and until they have double diabetes. They might not have that much of obesity. Their liver fat might not be that bad. Their hypertension might not be there even unless and until the individual develops renal complications. And I think we are very laid back when it comes to cardiovascular risk management in type 1 diabetes. That's my take. Maybe one of the things that happens is everybody is happy for them to, reach that age of 25, and then things fizzle out in terms of management of type 1 children, because there is no transition of kids from young physicians to the adult physicians. So I think things go wrong there. So risk assessment is very important. And like you've pointed out, unlike in type 2s where you have a lot of good validated risk engines, in type 1 we don't have that kind of a validated tool which would actually be useful. And in terms of hypertension management, again, would you be very aggressive? Because in that particularly one slide, you clearly showed us that, again, if I have to find out which of those risk factors were probably one of the worst, one of them was hypertension. So again, when would you suggest starting to screen for hypertension in these children or young adults for management? And what guidelines would you use? Because the adult criteria don't fit in for the kids, because you need to have normative data for adolescent and young adults.
Once again, it's a tricky question. What I will do is, I would have been following up the patients. Of course, the moment they develop, even say 130/80 with microalbuminuria, definitely will be starting. Pure hypertension, if they have had, say, previously normal values and there is an increasing trend, that's the time when actually I will start using them on an ACE or an ARB. And the cutoff could be anything more than 130, above 80. So they have been 110, 70. And over a period of an year or two, I find that that's increasing, repeated readings, more than 130, 80. Probably that's the time I may start on ACE or an ARB. Of course, once again, post pubertal thing. One of the things which has been found actually is the pre-pubertals. Of course, the theory, this is what we were when we were taught. Pre-puberty doesn't contribute much to the complications. So post-puberty, I find an increase. That's the time I will actually start them.
Right.
And
Last question, which Dr. Archana will actually continue in our talk. Now, what about double diabetes? You know, we have a lot of type 1s who have other features of metabolic syndrome. What about cardiovascular risk in them?
I think it's increased in them because they also develop some features of insulin resistance and some contribution. See, I put it in that slide, the difference in type 1, the contribution of insulin resistance is just 1+ compared to type 2, where it's 3+. So in this type of patients, probably it is +2 or going to +3 as the contribution of that to cardiovascular risk. So yeah, in them, probably I'll be a little bit more aggressive. But then I hardly can remember anybody having that type of a diabetes because I have majority of my type 1s are very lean. Exceptions are there, where in fact I put them on even liraglutide actually for one of the patients, and she did lose weight also. So these are the type where I'll actually be more aggressive in treating the cardiovascular risk factors.
Sir, may I ask?
Yeah, sure.
So what about the prepubertal persons with type 1? What do we do if the lipids are high and the blood pressure is on the higher side?
If they are high, definitely we will treat them.
Okay.
Definitely we treat them. See, now I told you, including familial hypercholesterolemia, though it was considered 10, they have brought it down to 8 now, in fact. So I will probably treat them with a statin. If there is hypertension, yes. But the general rule is pre-puberty doesn't contribute to the complications. A general rule, I won't say 100%. So that's a reason. But if you find them, please treat. You have to treat them.
Okay, sir. Thank you very much. And we'll move on to Dr. Archana Sharda for the last bit of this particular session. Madam, I think, needs no introduction when it comes to type 1 diabetes. Probably one of the best clinicians looking after type 1 children and young adults. Quite a role model for all of us when we talk about management of type 1 diabetes. And ma'am is going to talk about weight gain issues in type 1 diabetes. You know, like Dr. Ganpati sir said, that maybe a significant proportion of our type 1s are lean and thin, but the moment we actually start treating them properly, you know, this bit of so-called leanness actually goes. And a significant proportion, I would say in my cohort, at least about 20% of children and young adults with type 1 diabetes are actually ones who are overweight or obese as per whatever guideline or cutoffs you use. Ma'am, the stage is all yours.
Thank you, Dr. Sutra. I'll just share the slide. Yes. Yes. Thank you, Dr. Sujoy, for the introduction and the topic. I think we've been going through this, the new drugs that we talked about, the CV risk, and now again, weight gain. This is a topic. These are 3 topics which are normally not talked about. And hence, it's very important. I also had to think about, is it a fact? Is it something they're just worried about? Or is it really happening? And then we realized that, yes, it's a fact that although it was once rare, we always thought about lean people with type 1 diabetes. It's now an increasingly frequent problem. There's a lot of evidence which is now emerging, as was mentioned by Dr. Panthi also, that obesity contributes to the insulin resistance, dyslipidemia, and cardiometabolic complications in type 1 diabetes, as we were talking about double diabetes right now. So if we look at at the observations, do we have studies showing this is happening? Yes, there's so many studies, the Search for Diabetes in Youth study, which use the anthropometric measures. And the important thing in this study, I will not go through the numbers, there are multiple studies. I could not come across any Indian studies which would show us obesity studies in type 1 diabetes. Maybe it's time we start doing that. But the strength of these findings were that the comparison of the same period and ages while contrasting individuals with and without type 1 diabetes. So that was very important. Again, in the type 1 diabetes exchange registry, which was seen from Germany, Austria, and United States, the greater BMI index was seen as compared to the WHO international norms for respective country-specific national norms. So it is definitely there. And as Sir also mentioned in the edict, there was a large increase in the weight, which was seen from 1% baseline to 31%, and that was in the intensive arm of insulin treatment, which we will be talking about. So although the limited studies are there, but all of them, when they are matched for age, sex, and time frame, they are now showing that there's a trend of obesity in individuals with type 1 diabetes. This is also, as Dr. Sujoy just mentioned, that 20% of his population he's seeing people who are overweight. And with my case also, although I work in the rural area, yet I am finding more and more people, maybe because of the lifestyle change or the factors which we are going to talk about now. But yes, we are finding more and more people shifting from the lean to the obese side. Now, this is a very famous, well-known fact. And in the DCCT, we found that the intensive insulin therapy and the tight glucose control gave two untoward actions, and that was the weight gain, which was threefold higher than in the intensive arm. So that's like around 4.5 kg was observed in this, and also more hypoglycemic events. Does that mean we will not give them a tight control? Absolutely not. And that would be the final take-home message, because ultimately we are preventing, as shown by Dr. Ganpati, all the other cardiovascular risks. But again, weight gain is a significant factor which is now contributing. And there we come to the point which was just taken of double diabetes. Already we are talking about the youth with type 1 diabetes is predisposed, as was shown in the last talk. But when they're on top of it getting overweight and it becomes a double diabetes, there is insulin resistance to their exogenous insulin, and that itself becomes a much higher risk for cardiovascular disease. So the whole reduction of risk, the risk factor, risk scores, the methods that we had talked about, now it becomes a very serious issue when we are talking about our young people for type 1 as well as type 2 in their cardiovascular risk. So what could be the mechanisms of this weight gain? First thing I thought is what's most important is what we do every day, and that is our insulin therapy. So the intensity of insulin therapy, as we said, the DCCT trial showed us that the tighter the control, the more the weight gain was seen. But can we do away with tight control? Probably not, and we should not. And then again, the thought is of the type of insulin therapy. There are very limited studies, but these studies have shown the NPH had more weight gain as compared to Detamir. Detamir had more weight gain as compared to Glargine 100, and Glargine U100 had more weight gain as compared to Glargine 300. So limited studies, but there is something probably that we can do about it. Again, we know the growth hormone and the insulin-like growth factor. This non-physiological mechanism causes an imbalance between the catabolism and the anabolism. So these could be some of the factors. Double diabetes we have talked about, so I'm not going to go into it. But again, the weight gain and the insulin resistance cycle has to be recognized and treated early. That is the point we're going to take home today. And the lifestyle. So nutrition, I think it goes without saying, and that will be that has happened even in my rural kids are now swigging and having all kinds of junk food. So high carbohydrate diet, lack of physical activity with digitalization, and very, very important part is the behavioral and the psychological, social factors. This is also what is influencing the nutrition and the physical activity. So even in in young people, even without type 1 diabetes and type 2 diabetes, this is a very important factor. So with type 1 and type 2 diabetes, of course, all the peer risk factors and the emotional factors do play a big role. So the family factors, the personality factors, when was the diabetes diagnosed, was there weight gain, weight loss, and then the intensive insulin treatment once it started, there can be a recurrent hypoglycemia, which leads to binge eating, again leads to depression, and that cycle keeps on going on. The other side is a weight gain, which leads to a very strict eating, lots of carbohydrate counting, parental pressure, which again leads to eating disorders. So both sides, swinging to both sides, can be creating eating disorders in the young ones. Hypoglycemia, surprisingly, is a very important factor. I just mentioned it can lead to food craving and binge eating, but just a thought that the last point that I mentioned, that 15 gram, that is just 60 calorie carbohydrate rescue for hypoglycemia once a day, which I find so many young people will do to access something they want to eat, can cause 2.7 kg weight gain throughout a year. So we know that young people end up consuming much more than does this. So to go very quickly, because I'm aware we are short of time, there's the energy imbalance that occurs in type 1 diabetes. The other mechanisms for the phenotype, obesity phenotype in type 1 diabetes could be genetic, epigenetic, microbiome, adipose tissue dysfunction, mitochondrial dysfunction. All these are under research in a very, very intensive way. It's too elaborate to mention here, but something we should be aware of. Another very important thought I felt we should share is the achievement of well-controlled type 1 diabetes due to insulin intensification. It reduces the urinary glucose losses, the resting energy, the thermogenic energy from the food, but does not affect the food intake. Hence, there's a net positive energy balance and weight gain that we see. What can we do about it? We have talked about all the drugs, so I need not go into that. And I also mentioned that I have used some of them off label, but the obesity drugs, anti-obesity drugs, are again something to think about. Bariatric surgery has been recommended. But nutrition therapy, physical activity, and exercise ultimately remain the cornerstone. What we really need today is a very intense study where we can go for a type 1 diabetes specific weight management recommendations, which take everyone's expertise, as well as an integrated evidence-based characterization of obesity in type 1 diabetes. So if we could have that, and it's time to go forward. And thank you so much. I just wanted to make that point here. And these are the references that I used while presenting this. Thank you so much. So,
thank you, ma'am.
So, Dr. Joy, I was very quick. Yes.
Yes, you were. Very crisp and to the point presentation. In terms of weight management, I think one of the things that you've highlighted is it's not as uncommon as we thought before. And it should not deter us from going for tight control. So, and what you have highlighted is the overcompensation for an hypo leading to weight gain. And again, the concept that it's double diabetes that actually is an entity. So I'm not going to ask you any more questions, ma'am.
Yes.
I'm just going to 30-second summary of what we've learned today in this entire session. We first started up with non-insulin therapies. There we realized that it reduces the risk of hypos, all of these drugs that we are using. They are all off-label uses. They probably reduce the dose of insulin requirement, but we don't have definitive evidence of improvement in A1Cs and weight and long-term outcome data. And probably metformin is going to be the one that we are going to be using most commonly. The second bit of the CV risk, these are the highest risk people in terms of CV risk, in terms of comparison with the general population. And 1% HbA1c translates into 18% increased risk of cardiovascular disease in type 1 diabetes. We need to be very, very, very aggressive. And glycemic control is probably much bigger contributor of CV risk in type 1s compared to type 2s. But the other CV risks will also actually have to be tackled. And good glucose control reduces the CV risk by about 42% in type 1s, unlike in type 2s. In terms of the weight issues, very common, shouldn't deter us from going for tight glycemic control. We've got to think of the insulin regimes and the adjunct drugs, and maybe probably looking for eating disorders as well, and try and not overcompensate for hypos and avoid hypos. So that's what I have learned from all of you and the experts in the last half an hour. Thank you very much for an excellent session, and I hand over to Dr. Neeta. Thank you once again, ma'am, for giving me this opportunity.
Thank you, Dr. Sujoy.
Thank you very much. Thank you so much, Sujoy and the entire team. You all have done exceedingly well. And we have some very good takeaways about these important, not so much talked about points in type 1 diabetes. Thank you all very much.